So with that, we will get our webinar started on pain and identifying the causes and finding care. It's my pleasure tonight to introduce our speakers. We have four outstanding speakers from across the world. We have two here in the States, one in New Mexico, one in New Jersey, and then we have two folks joining us from Hong Kong. So we have a truly international group tonight that will be speaking. First, I get to introduce Jackie Chan, who is a occupational therapist in Hong Kong. He has his Master's of Science in Stroke and Clinical Neuroscience at the Chinese University of Hong Kong, and he completed advanced specialty training in orthopedics and traumatology for occupational therapists. He has extensive working experience in chronic traumatic disease at the Queen Mary Hospital and David Trench Rehabilitation Center in Hong Kong. Our second speaker tonight is Dr. Marvin Chung, who received his undergraduate medical degree from the University of Hong Kong in 2014. He's completed his orthopedic specialty training in 2021 and obtained his fellowship from Hong Kong College of Orthopedic Surgeons. And he has also done numerous fellowships at world-renowned centers, including Mass General Hospital in Boston. Next, we have Dr. Deanna Mercer, who graduated from medical school at the University of New Mexico. She completed her shoulder and elbow fellowship at the University of Washington, and also completed a hand fellowship at the University of New Mexico. Dr. Mercer has hosted many teaching labs across the nation and served as faculty for numerous courses. And last and certainly not least, we have Alta Fried, who is also a certified hand therapist and hand therapist director at the Atlantic Physical Therapy Center. She has extensive training in the treatment of hand and upper extremity. She has fellowship training at the prestigious Philadelphia Hand and Shoulder Center, and has completed over 4,000 hours in hand therapy practice to receive her certification in hand therapy. She has presented at state conferences and has published in articles in Advanced Magazine and ASHT Times. Her training includes a wide variety of conditions with a special interest in complex traumatic hand injuries. It's all yours.
All right. So my charge is how pain signals in the body. And we've really tried to make some correlations with things that really make sense. So the nervous system of the human body is like the wiring in your house. And so you have sort of your main meter where the electricity comes from the city and it comes to a main box. So that's like your brain. And then from your brain, it then goes into some other branches that are still quite large and contain, for example, if you're thinking about your house, it goes to like your kitchen and your dining room and your living room, whereas the other one may go to, your bathroom and your bedrooms. And so in the human body, it goes from your brain into your spinal cord. And then from your spinal cord, it breaks up into these big nerve trunks into your arms and into your legs. And then from there, it really becomes very defined and branches into all the different parts of your arm and legs. And so, for example, you have a very specific nerve that goes to your thumb, just like in your house, you have a very specific wire that goes directly to an outlet, for example, in your kitchen. And so the way that the nervous system in the body is organized is just like that. It's very, very sort of straightforward, basic, and it's consistent. So the way that I'm built, the way that Stephen is built, the way that you're built is very, very consistent. And so we can actually actively find these nerves in the body exactly where they should be. And they are covered in something called myelin, which is just like the insulation in the wires of your home. So if you think about the copper as your axon, which is the nerve part of that is going to go to your muscle, like this is going to go to your toaster, right? And the blue or the tan or the purple or the black or green, all of this is like the myelin sheath. And so the nerves are actually covered in this insulation material that is called myelin, and it is divided into these different components. And so the big nerve trunk has the components that go to your legs and your arms and your back. And then around those specifically, you have this insulation, and we'll talk about why that matters. Now, when you have an injury to a nerve, which we see all the time, like I had multiple nerve injuries today in my surgical day, then you can connect them back just like splicing wires. And when you connect them back, it's not instantly on. It has to regrow. And so when you cut it, for example, in the blue here that you see where there's sort of a truncated end, if you connect the nerves at this level, it then grows a millimeter a day. And so you can envision that if you have a cut like that's way up in your arm versus a cut that's like next to your wrist, it takes longer for the nerve to regrow from the part that is more closer to the shoulder, for example, than something that's closer to the hand. And so that's important to understand because nerve regrowth takes time, which can be very, very frustrating for surgeons and patients. And then there's also regenerative time, meaning that the nerve has to get to the muscle and do its magic at the muscle to make it contract. Now, the longer you wait to repair a nerve, the less chance there is of getting function. And why is that? Well, once you cut a nerve, the nerve starts to degenerate and sort of dissolve, and then the part of the nerve that activates the muscle, so the one that is making your fingers flex, those connections start to disappear. And so if you do it immediately at time 0, meaning you cut it today and you fix it today, that is a way better situation than if you cut it today and you fix it in 6 months, or even if you fix it in 3 days. Like, there is some difference in the regenerative potential, meaning how the nerve can regrow, and then how the nerve can actually function once it gets there. So the nerve gets to the muscle and it still needs to have, the little apartments to move into. And if all the apartments are closed because the muscle has degenerated, then it can't get there and do its job. Now, how do you repair nerves? Well, in a lot of situations, you can actually sew them together just end to end. So you cut the nerve, comes apart, you sew it back together again. And then we use these little conduits, which are very much like this black tape here, that around the areas of repair that actually protect the repair so that it doesn't grow a neuroma, meaning the nerve fibers don't like escape and grow disorganized. They stay together and they're contained within that conduit, and then they can regrow back down the nerve down into the muscle or wherever it's going to innervate. And again, like, healing takes months. This is a really important concept because you're growing a millimeter a day and your hand isn't doing anything and you're wondering why and did it work? And 70 to 83% of the time it works really well, but it really does start like a dim light. So initially you have, you think, oh, I think it's something is starting to flicker. And then all of a sudden over the course of more months, then it turns into a bright light where you can actually make a full fist.
Good evening, everybody. Thanks for coming on for those that just joined. So Dr. Mercer just really nicely explained the actual physical nature and makeup of a nerve. So we'll talk about how nerves get injured. So as some of you know, when you touch something hot, you touch something cold, you feel it, right? And those are our nerves. The nerves are very close to the surface, very close to your skin or under the skin, and oftentimes they're easily injured if you sustain a cut. But there's also different ways that the nerves can get injured. They pass through very tight spaces sometimes in your body, which we can and will talk about as tunnels, which can be another source of injury or insult. I would say more of an insult than an injury. And as we learned, nerves are long wires that pass messages to the brain. And as with all wires, they can be stretched, which causes a malfunction as well. So if we divide nerve injuries into 3 sections, 3 categories, you can have a stretch of the nerve. So if you think about a rubber band or, some sort of string and you stretch it and it's kind of stretch to the max, you can have a cut from a knife, a laceration, something sharp, or you can have a compression, which we'll talk about a little bit more later in this talk, which is the nerve getting compressed in a tight space or a tunnel, as we discussed. So a compression of the nerve, if you look at the pictures to the right, they are quite clear of what a compression is. So we have several tunnels in different areas, different spaces of the body. Some of them are more common than others. And what happens is that the nerve passes through a tunnel together with other structures. And if there's anything added to the tunnel, essentially a tunnel with no space, that'll lead to compression. So if you look at the image to the right, we have a median nerve, which passes through what we commonly know as the carpal tunnel. And what you can see to the right of that are some of the tendons. So if we have any swelling, any pressure, any of the tendons getting larger for any reason, that nerve will get compressed. Whereas if you look at the picture on the left, we have a healthy carpal tunnel where everything's in the right spot, nothing is compressed or damaged or insulted. As we said, this can occur in multiple areas of the body, and wherever there's a nerve, there can be an injury technically, and wherever there's a nerve in the tunnel, there can be a compression. Now, as we know, if the nerve is compressed, if the nerve is stretched, it cannot function and it cannot do its job of sending messages, as Dr. Mercer so nicely described. So here is a nerve stretch, and quite honestly, a nerve stretch is when the nerve is stretched beyond its limits of elasticity. So if you think about a rubber band that you've pulled too many times, or a rubber band that's just been sitting there and it's old, and you just pull it, it's not as tight as it was. And the stretch of the nerve can vary in severity, so depending on what it's from, and it can be temporary or permanent. And there are different ways to sustain a nerve injury, whether it's a compression or a laceration or an injury. So there is high energy trauma, which can often have a multitude of different nerve injuries at the same time. You can have a laceration if there was something sharp. You can have multiple stretches, falling on the ground. So it's also kind of a nerve stretch, as we discussed, where, you can see the fall on the outstretched arm, obviously, which as hand therapists and hand surgeons, probably what concerns us firstly is a distal radius fracture, but any kind of stretch or elongation of that nerve past its limits, or direct contusion in contact sport injuries, or even just contact sports where sometimes you don't think you have an injury and there's a stretch or stress. And then as we move on to a cut nerve, which is maybe a little bit easier to understand, because if you think about the electrical wire, and pretty much a cut is where the electrical wire is broken. And there is a dead space in between the two ends of your nerve. So the message that you want to send to the nerve, to the muscle, is not going through. A cut nerve will often require surgical intervention to quite literally reattach the two ends of the nerve, or to do something else so that the nerve can grow into itself and continue to send messages to the correct muscles. Thanks for that. And we'll continue with Jackie, who's an OT as well.
Thank you, Ota. Good evening. So I'm Jackie. I'm the occupational therapist from Hong Kong. And in the next slides, I'm going to talk about the compression of the nerves in our arms. And there are two types. One of the most common type is the median nerve injury. If you're doing tennis, golf, or weightlifting, if there's a direct blow in the wrist, or you have a repetitive hand or wrist movement, sometimes you may feel, or for some people, you may feel numbness in the thumb, index, and the middle finger, or the weakness in the thumb in the later stage. So the first nerve that we usually get injured is the median nerve, and the reason is usually about compression. So I'm going to talk about the carpal tunnel. So the carpal tunnel is special. It's a very narrow passageway in your wrist, which it's bound by the wrist bone at the bottom and covered by the transverse carpal ligament on top, just like a tunnel to cover the whole your whole wrist. And there are so many wires that go through the tunnel, including the muscle tendons, many of them. But unluckily, our median nerve also go over there. So if you're having a swollen tendons, if you're moving your wrists or your hands too much, your median nerve will get compressed. And over time, you will get a syndrome that's called, in the next slide, the carpal tunnel syndrome, which you have tissue swelling, repetitive motions that compress the nerve for a long time, and you will feel the fingertips. Some patient will say, all my fingertips are numb, or in definition, you're having thumb, index finger, and middle finger, and half of your ring finger, because that's what the median nerve supplies of the sensation of our hand. So if you're having 3.5 fingers numbness, you're basically having carpal tunnel syndrome. And the second nerve that we're going to talk about is the cubital tunnel. So the cubital tunnel, it's about the ulnar nerve. It's a bony trough which houses the passage of the ulnar nerve. It's not only the ulnar nerve, it's surrounded by some soft tissue. And it's called the funny bone nerve because sometimes, if you can experience that, if you are having a blow over your elbow, you will feel an electrical sense or a funny sensation. So that's the ulnar nerve, and that's the cubital tunnel. If you're doing sports like baseball, tennis, and weightlifting, or cycling, and just like the median nerve, if you're having a direct blow or impact, or you're having repetitive elbow flexion or wrist pressure on your cubital tunnel, so you have numbness in your ring and little finger. Sometimes, for later stage patient, they will have difficulty in their fine motor skills because the ulnar nerve also supplies some of the motor muscles in our hands. So, for cubital tunnel syndrome, means you have spent a lot of time bending your elbows, like driving or typing. So you're compressing the ulnar nerves in the cubital tunnel. And what you'll feel is the pain inside the elbow. And also, this time, it's not the 3 fingers. It's the numbness of your ring finger and the little finger. So it completes the whole picture. If you have numbness in the fingers, you should be able to tell which nerve I got injured, or maybe both nerve is injured. So compression is only one of the reasons that we have arm pain we have pain in our upper limb. So the next part is the traumatic part. So for the radial nerve, if you're doing skiing or contact sports, or you fall with an outstretched arm, and if you're having humerus fracture, you're probably going to injure your radial nerve, and you have numbness over the back of your hand. So we talked about the palmar side of our arm earlier. This radial nerve is governed the sensation of the back of the hand. And for more severe case, you may have difficulty straightening your fingers. So if you're for what we talk about, it's the lower part or the more distal part of our arm. If you're having a more proximal or injury that closer to the neck, you may get the brachial plexus injury, which we have an extensive network of nerves at the shoulder and the armpit level. It's usually more, you can find this injury in more vigorous sports like football or rugby. Usually it's about the direct trauma, traction, and basically you will feel the whole arm is weak and numbness if you're having the brachial plexus injury. And of course, a heavy cut or transition will get yourself injured. And I'll go to the summary. So there are two major nerves in your arm, the median nerve and the ulnar nerve. And you can injure them by compression, which is over a long period of time. And or if you're having a high energy sport or activity that you may got a traumatic event that may injure your radial nerve or brachial plexus, or if you're having a cut or injury over the whole nerve, which is easy to understand, you will get the nerve injury too. So next up, we're having Dr. Marvin Jung to talk about what can we do to a nerve injury in your arm if you think you have an injury in your arm. Thank you.
Thank you, Jackie. So I'll be talking about what you can do if you think you have a nerve injury. So the first step is always to get a proper diagnosis. So you have to know that you actually have a nerve injury in order to get the appropriate treatment. So the first step is always to seek medical attention early. So it's important to remember that if you have numbness or weakness, or if you feel your hand or your arm is not functioning properly, it's always not normal. So no matter what you think it is, it's always important to seek help from professionals, from medical healthcare professionals in order to get the correct answer. So if you have an early diagnosis and hence the early treatment, you're always having a better outcome. And because some of the nerve injuries are irreversible or are not completely reversible, so it's always important for you to have a early diagnosis before things are beyond salvage. So it's this would be the first important step. So what do you expect from your doctor? So if you go to your doctor or your healthcare professional, what are they actually doing to help you get the correct answer? So the first step that they do is always to take a complete history. So they need to understand your story, what actually happened, and they will ask what any injuries you have, any work that you're doing that makes the nerve are more likely to be injured. So, and then the next step will be to physical examination. So they would do some examination movement in your hand or your arm to look for any objective evidence of nerve injury. So they will be testing your sensation, your movement in different muscles, different tendons, and also to do some special testing. So there are some other special tests, for example, bending your wrists, bending your elbow, tapping on your wrist to see if there are any signs of a nerve compression or nerve injury. And then sometimes if the history and also the clinical examination is not enough, and there are further investigations for example, some tests that doctors would run to confirm the diagnosis, and they're called the nerve conduction test or the electromyography, meaning there are some additional testing that doctors would do to localize where exactly the nerve is injured and also which nerve is injured. Okay, so the second step is, oh, there are so many medical professionals out there. So who should I find? So there are a lot of doctors that you can go to. So for example, if you have a non-urgent issue, it's always nice to go to family doctor. For example, if I have numbness in my fingers for almost a year, 2 years, then these are likely non-urgent problems. Of course, it's not good to wait, but if the problems have been there for quite some time, it's always nice to go to family doctor, because the family doctor will probably know you for a while already, so they would have sort of an understanding of your background history, and they would also know your past medical history, and they are at the position of thinking what would be happening to you if you have nerve symptoms. And then if you have an urgent condition, for example, you had an injury a day ago, or if you have like a wound where you cut yourself with a knife, it would be nice to go to the emergency department sometimes, because there might be urgent interventions or treatment that you should get at the hospital or an urgent care facility. And if you think, if your family doctor thinks it's probably some brain or nerve injury, then their neurologist might be a person to go to. It depends on whether the family doctor or the emergency physician thinks that additional referral is needed. And if they think it's a hand and upper limb problem, and you have tried some conservative treatment, or if there's a gross injury where the nerve is cut, sometimes the surgeon would be the person to help you repair these nerves, or to do some surgical interventions to help with your nerve severe compression. And then, so there are a lot of nerve specialists around. So the Global Nerve Foundation has a really nice website where there is actually a healthcare provider directory. So no matter where you are over the world, so not just in America, but also in Asia, in Europe, in Australia, there is actually a list and a map of healthcare providers available to treat these nerve problems. So there are actually a lot of different healthcare professionals around in different specialties, not just hand, but also, for example, if you had headache or neuro problems or pediatric problems or even podiatry. So a lot of specialists are around you, and it's the Global Nerve Foundation is a good starting point to know who to find help. And then the next step would be to go for a non-surgical treatment sometimes. For example, if you have a compressive neuropathy, meaning the nerve is compressed and is not functioning well, sometimes very easy treatment would already be enough. For example, you can do a splintage for carpal tunnel syndrome where it's at the wrist, or some elbow splint for cubital tunnel syndrome, which is at the elbow level. And there are exercises, which will be covered in the next slide, that the therapist can teach you to exercise your nerve to see if there is any improvement in your symptoms. And of course, sometimes you have to modify your activities as well. If you're doing a lot of heavy lifting, manual work, it might sometimes be better for you to have a little rest in between, or to modify your activities a bit. For example, not lifting as much or as heavy. That gives the nerve some time to rest. And so nerves in general will feel better if they get to rest, because a lot of the times these are compressive or inflammatory problems. So if you rest them, they can have a little more room to improve and to get some rest for the nerve fibers, for the signals to go back. So if you rest the nerve in an appropriate position, for example, in the splintage, for the wrist or your elbow, or if you're just in a relaxed position, not doing some awkward posture with your hand, your elbow, or your arm, or if you can do some nerve gliding or sliding exercises, For example, stretching out your arm, doing these nerve gliding exercises as shown in the right diagram. So all these different nerves that was covered by Jackie will have different positions for comfort and also different directions in that where you can actually exercise and glide them. So the final step would be to go for surgery if that non-surgical treatment fails. So what do you expect if you need surgery? Before the surgery, you have to discuss your medical history or many medications with your doctor. So they could have some adjustment in terms of these things if necessary. And sometimes you might have to fast before surgery. So if there are any specific instructions given by your healthcare providers, you have to follow them. During the surgery, nerve surgery could be done under local anesthesia. So where they give some medications underneath your skin to numb that area where it's operated. You might have some sedation sometimes to feel, more comfortable. Or if it's a big surgery, major surgery, you might have to do it under general anesthesia. So if it's a minor procedure, it's typically a day surgery. So you don't have to stay inpatient in the hospital. You can come in and then do the surgery and then go home without staying inside the hospital unless it's a major surgery. So after surgery, it's very common to have a certain degree of pain and swelling. So it's impossible to have no pain at all. So of course, your healthcare provider will be giving you medications, prescribing these to help you feel better and also to do appropriate exercises. There will be stitches sometimes and bandages at the surgical site. You might need a period of rest. So it's important for you to know that your hand or your arm have just undergone some surgery to help you get better. So you might need to rest it, not overwork it in order not to waste the surgery. And a very important part would be to go through hand therapy to regain motion, strength, and function. And that would be it for our steps of approaching nerve injuries. And we would welcome any questions if you have any.
Excellent. Thank you all. As Dr. Chung mentioned, if anybody has questions, please feel free to put them in the Q&A. I actually had two kind of on the topic of what to do if you think you need nerve care. I guess starting with the two surgeons, Dr. Mercer and Chung. What do you guys typically go through before deciding on surgery? So what are the steps that you as surgeons take if a patient kind of comes in? Do you try physical therapy first, or does it vary case to case on the symptoms that the patient is displaying?
So I can start. It really depends on the problem. And so there's lots of nerve problems that come about. But if this is a problem of a transected nerve, that is something that needs an operation. And you can really determine this based on the clinical exam. You lose feeling, you lose your ability to move or fire muscles. And so on a clinical exam, you can really determine like what nerve, and if it's partial, if it's complete. It's really pretty textbook. If we're talking more about like compressive neuropathies or other nerve problems that, for example, the nerve glides that were described would be appropriate for, in that situation, sometimes if the symptoms aren't too severe, you can absolutely do therapy, bracing. You can do, dietary modifications. I have patients tell me that, after they eat Thai food, their median nerve symptoms are a lot worse because they retain water because it's so salty. And so really it depends on the clinical examination and the problem that presents.
Yeah, I agree with what Dr. Mercer said. So often at times when patients first present, it really depends on how bad they present. So some people might present very late and that the symptoms are already very severe. The nerve is already in a very bad shape. and it's quite unlikely that conservative treatment or splintage that would help these patients. So sometimes if you're too far gone, or if the symptoms are very severe, then we might have a higher threshold of proceeding directly to surgery. But of course, we always have to discuss with patients. They would have different demands. They would have different expectations. For a young person, compared to a very old lady in a care facility, the expectations are often very different. So the decision to whether to go for surgery or to go for conservative treatment, usually it's a discussion together with the patient, the carers, and also the doctors themselves.
That makes a lot of sense. Thank you. And then maybe for our occupational therapists, like the difference between like pre-surgery or post-surgery. Jackie, maybe could you walk us through, like, somebody's coming in trying to avoid surgery, what does that look like, and how do you approach that care?
It depends on the different conditions. So if you're considering the surgery, but you're hesitating about it, there are some conservative treatment that can help. But usually at the end point, it's sometimes if the symptoms not severe, it's about the activities modification that we talked about earlier. It's not about the treatment that you've got. It's actually how you modify and how you space out, how you adjust your activity levels, that maybe your age or your demand is too high. That's why you're having this nerve problem or compression problem. Then the conservative treatment is kind of something to help a bit, but usually it's how you adjust your whole life on it to compensate or to tackle the whole nerve problem in the long term.
Excellent. Thank you. And then also maybe ending with patients coming in post-surgery, like what does that look like, working between like the surgeon and the patient, and how do you approach that?
So as Jackie mentioned, if it's a conservative treatment, the care is going to be more long-term activity modification, patient dependent on following your guidelines. And, the visits are usually just a couple visits to put them on the right track. Give them exercises for when they have a flare-up or things like that, and exercises or modifications how to avoid this. Whereas post-surgery, you would want to get, from the surgeon if a nerve was fixed, which nerves were fixed, how it was fixed. You want to know where in the body it was. Was it in the upper arm? Was it lower down in the arm? And then if a nerve was released as far as a compression, you would want to know that as well. So again, exactly knowing where it is, what's your timeline of healing, and how the surgeon fixed it is usually great when you have communication with them, direct communication. And then initial therapy post-op would focus on swelling, scar tissue, obviously if there's a wound, and early retraining of the nerve. And as well as desensitization. And as Dr. Mercer mentioned in the beginning, it can look like you're doing nothing or not accomplishing much. But knowing to maintain passive range of motion, even though right now your fingers are not moving or your hands not moving, is important for when the nerves are back on track and back sending messages to the muscle, or the tendon to do its job. So the treatment, I think, would look very different.
Excellent. That makes sense. But thank you all again for taking the time to participate in the webinar tonight. Thank you, speakers. We really appreciate the time to share your knowledge and information. As I mentioned, we will be sure to get this up on YouTube and send follow-up as well for everybody. I hope everybody enjoyed the webinar and have a great evening.
Thank you, Stephen. That was great. Appreciate it.
Thanks, everyone.
Have a good night.
Thanks, everyone.